Wonderful. Weren't they great? Weren't they? Let's give them another round. So, as we give Ms. Close a chance to sit down, I think that this point about the prevention, and there's actually been studies out of Denver that show that starting the prevention early saves money over the course of a childhood. And going back to the question someone asked before about fear, we know that if their first experience with anything in their mouth is positive, they will have this reaction like some of our children have had of loving going to the dentist. So if we can have that preventive step happen so they don't have problems when they get to the dentist, and then that first dental experience is positive, it relays down as they grow older, and that continues. But the point of today's session, this particular part of the session, was about this integration piece. So I have a few specific questions I'd like to start with. The first is that a lot of these attempts to integrate oral health and general health began with referral systems. And there can be a whole range in terms of what a referral means. It can be writing it on a piece of paper or just saying go and just assume that people will follow us, all the way down to actually making those appointments or literally walking them to another chair or having someone come to them in their chair. So I'd love to hear from you all about that range, which has been most common. Well, we know what's most common, but what are the weaknesses with the more common approaches, and how are the best, most effective ways to integrate care with referrals? Any of you, please.
Can you hear me? Okay. Okay. Well, for North Carolina, I don't really know exactly, what the most effective referral method is. We really haven't evaluated that, but we do know that getting kids into the dentist early is important, even with medical providers doing preventive oral health services, because children receiving their preventive oral health services in the medical home, when they not have and they develop early childhood caries, they don't get treatment. And so making that link is important. And we have tried doing a pilot that having education for general dentists to help them be comfortable seeing young children and getting them on board, and then having our medical practices make referrals, and that worked great. We still only had about 50% of children actually make a dental visit, and once again, we had some parents that had barriers, which we were not looking at in this project, so we don't know exactly what they were. But it was very labor intense to do this project. So it involved the risk assessment tool. And I know that there's reluctance for medical providers to add a risk assessment tool to their already jam-packed well-child visit. So I'm not sure. I don't know. It's a dilemma. And I thought it was interesting to hear today from some of you about maybe doing that somewhere else, doing that risk assessment in another venue. I'm not sure where that would be, but I do know that, even within a group of children, some are more at risk than others. And I think the evidence shows us that for children at high risk, the early dental visit is important, and that's what we need to figure out.
From a referral perspective, I think, I strongly believe that if we can make it really easier for the patients, I think that's kind of the foremost way of making it workable. If it's, from a dental practice perspective, I've always historically done a very cold handoff. You got to go see your medical provider, and similarly, my friends on the medical side have done that. But the last few years that I've been really engaging more in terms of trying to get to understand how the medical practice works when it comes to oral health and dentistry. A lot of the anecdotal kind of, feedback that I've received from my medical colleagues have been around, we sometimes even hesitate to tell it to our patients, go see your dentist, because of some of the access issues and the insurance issues. In fact, a couple of them even shared that, okay, I've tried to refer, but then the patient came back and told me that, the dentist was not able to see them for many reasons that we are all aware of. So I think from in terms of your question, what is the best model for making sure that the referral gets closed out? I think it's what John and his team are doing, kind of having really co-located medical and dental care, access to that. I think, from a patient perspective, it's just kind of for me I'm right there. If my medical provider wants me to see the dentist, I can just kind of make sure that's taken care of, and vice versa. The approach that we took at the Marshall Clinic Health System was mostly around, how can we do this in terms of an electronic referral, where we still didn't want to put the burden on the patient, but it's the care team approach where, trying to work that list in terms of if I'm a medical provider and I wanted to refer my patient to you as a dentist, I would make sure that, I get that referral into the, clinical referral manager. It's a list. So the closest dentist, or dental practice, actually, their team is looking at, okay, here's, a person with diabetes, and there's a referral that's come into our system who needs a dental visit, and I can clearly kind of take that off of the list and make sure that it's completed in a more of a closing out that complete referral rather than just relying it on the patient to kind of calling up back and forth. So.
Okay. What we've learned in the safety net setting, many of you have heard the cliche, if you've seen one health center, you've seen one health center, but there were some common themes that we learned from our both pilot projects and demonstration projects, as well as some really good best practices that have been shared. One of the first and foremost was scheduling before the patient leaves the medical appointment. So when there is an electronic health record or any means of, even if it meant the receptionist or the front desk person contacted the dental clinic or the dental provider, that seemed to be much more successful in a completed dental visit. So we actually did track that. The other piece that was really successful was a warm handoff. And so, especially if you're talking about patients that don't have a dental home, to have that introduction, it may not be with the dentist or the dental hygienist, but it could be a member of the team. That has proven to be very successful as well. The other thing that worked was patient navigators and transportation facilitators, as well as case managers, just having the discussion to understand what the individuals, the families, or the community's barriers are, just addressing those right then and there. That seemed to be a better likelihood of a completed visit and maintaining care. And then one really ingenious, when all the things this health center was doing wasn't working, they were constantly looking at changing their workflow, but they came up with a patient incentive that basically they gave the patient, because the patients weren't completing it, but they gave them, it wasn't a postcard, but it was something kind of cute looking, like a little widget, a little thing, and that they were informed that when they bring this thing to the dental practice, when they show up there, they get something in return. I don't recall exactly what that exchange was, but again, they showed up there with this, and I've seen this literally in a building where literally they'll take this yellow tooth, it could even be a sticky note, down the hall, and the fact that they turn it in, it made it easier for the non-electronic health records to count how many referrals they got, because they just have the stack of whatever the things are. But that seemed to also work as well in the absence of the electronic connectivity across disciplines.
Wonderful. Oh, do you want to add? Please.
So we had a similar experience. We called it a tooth pass. And what it was just a playing card with a tooth on it. And what we told the patient when they checked in, if we knew they had a care gap, we said, take this over to the nurse treatment room, and you're going to be in the front of the line. And just show them your tooth pass, you get in front of the line. Well, that wasn't true. What we did is, as soon as they went in the back to get their dentistry, their teeth cleaning, or the restorative, we would call over and say, hey, we have somebody coming over. They'll be there in about 20 minutes. They'll have a tooth pass. And that was the way to get them connected. If you make it convenient, it's around convenience. And then what we're so lucky in dentistry is we can make connections with our patients, because we got that hour-long visit. And so it's that personal conversation you really need. And hygienists are excellent at this. You really need to get this test done. And that personal touch, that really makes the difference.
Wonderful, thank you. Let's look at it from the opposite perspective. So medical providers are more likely to refer patients to dentists than dentists are normally to refer to medical providers. How can we encourage dental professionals to conduct screenings and to refer their patients to medical providers when necessary?
So one of the things that I didn't share in my presentation was around another initiative around blood pressure screening, kind of what John alluded to some of the health systems are doing, because clearly for it's common patient population that we are caring for, whether they walk into our medical centers or dental centers. So dentists, I have to kind of validate a statement that John had made. I think we are extremely good in closing the gap. And we are very analytical in terms of how we go about our practices. So we wanted to elevate the closure of kind of the blood pressure screening in the private practice. So as part of a health system core value, each multi-specialty, specialties were included, including dentistry, as part of a year-long kind of effort, where including dentists, all the specialties kind of, made sure if the patients who walked into their practice, if they were kind of, not necessarily at par, and, after the blood pressure screening, getting them based on the guidelines that was kind of, implemented across, using the referral that, we use. From a 72%, we went up to close to 89% for a health system, and dentists were probably the second most in terms of referring these patients into the primary care practice. So I think it's a health system. It needs to be part and parcel of how we do for our patients.
So we're still working on that, and but how we're doing it is by having care gaps, oral health care gaps, show up on the screen for the physician. And the two populations are, again, diabetics and children 1 year or older, to get them to our pediatric dentist. So we're making it part of the health record system. So they have that's been encultured to close care gaps. This is just another one that will be added to it.
Great, and I think I'll just mention one piece that we haven't really talked about today is behavioral health. And I want to put a little shout out to Hong Li at Asian Health Services in Oakland, California, where they actually, because dentists have more time in the chair, they decided to bring a behavioral health team in, and were stunned and saddened, but pleased that it actually was hugely helpful, where patients who kept coming back to the dentist to getting care and maybe were having trouble with exacerbation of mental health issues because of their oral health problems actually were able to get it redirected to care by getting the behavioral health services through that. So it's just another piece of our primary care connection I wanted to mention. But I'm going to take a little turn. Oh, no, please.
So just along those lines of behavioral health and oral health integration, it was very interesting. I mentioned the webinar that we did, which was integrating oral health and behavioral health in primary care. And that webinar was really targeting, as I said, the social workers as well as other behavioral health providers. What was very interesting and an unexpected feedback that we got was the dental community reached out and said, well, we really want a webinar for us, for the dental community, as to how we can incorporate oral health, incorporate behavioral health in our environment, because the webinar was trying to raise the awareness and education and knowledge of the behavioral health providers as to their role in oral health to help integrate in primary care settings. So I just mentioned that it was interesting. There was a huge swell of interest and demand from the dental community to ask us to do a follow-up on how they can incorporate behavioral health. And I can tell you, when I put my private practice hat on, as somebody that used to get all the referrals of dental phobics into my private practice from one of the dental schools in New York, I can tell you after one day where I had 4 dental phobics in a row coming in, it's very challenging for them, and it's very challenging for the providers and the teams. So there's certainly an area that would be wonderful for us to explore further.
Well, wonderful. And that helps me segue to the next question, which is about this education and particularly interprofessional education and how to use that as a way to help develop meaningful programs either on the predoctoral or the postdoctoral level or postgraduate level in terms of working together for this integration.
I can just talk to the training that we do for Into the Mouths of Babes. And it is CME certified through the American Academy of Family Physicians with an AMA equivalent. It's renewed every year, and physicians get an hour of credit for attending the training. Our web-based training will have it will also have a CME component. And I don't know that that's a huge draw for them when they take training. I think the draw is more so that they either are motivated to want to provide the services. That's the feeling I get, is that they know about it and they want to offer it. And there's a generous reimbursement. But I do believe that it has been integrated long enough that it's considered kind of a standard of care in North Carolina. And since Medicaid, I'm thinking I skipped that slide about training, but Medicaid does require training. So even though the trained participants can train others in their practice when they have new staff or new providers come on board, there are also residency programs that have it integrated. And so they may not get credit, but that doesn't seem to be an issue for them. But we do have it approved, and credit is awarded for it.
One of the things that we kind of tried to do as we were kind of working closely with our PCP group was to kind of making sure that the Smiles for Life curriculum was made available for them to take. The first year we kind of sent it out. It's not mandatory, of course. I mean, it's really hard to kind of put more burden on our docs as they're going through a whole lot of required CBTs and others, but we wanted it to be an opportunity for them where they had an option to kind of really go in as part of their yearly. Obviously, they would get the credits. Another thing that we also worked on was some of our grand rounds where we had dental researchers or other dental providers come and talk about the medical dental integration. We made sure that working through our Division of Education that there were appropriate credits available for our medical profession. But having said that, I think it really comes down to lack of time for all of the professionals. How do you integrate more? It's a continuing challenge. But I think from a literacy perspective, when patients ask this to their medical provider or dental provider, that's going to shift the way they're going to be thinking. Personally, I've done my bit as a healthcare consumer, where my wife and I give our docs a really hard time, and they know that I come from a research background. But I think as the patients really kind of take this upon themselves, that will slowly start tipping, more activated patients. I think that's an area as a researcher perspective, really looking at how do you disseminate information. Obviously, within the patient population, there are different cohorts in terms of health literacy, but even maybe starting off with some of the most educated, giving them the right information, and maybe sometimes you don't even have to give them. They are out there trying to kind of look at several forums and other things, having the right information available, directing them there would be helpful. That in turn will slowly shift this paradigm.
Thank you. And I actually had made a note here that I think health literacy can play a major role in increasing the patient's understanding. And so we can, while we're working on one side in the health professions to increase the supply of these services, also having patients requesting them and increasing the demand for it as well. Related to that on health literacy, a very quick question. Dr. Josko, you showed some really cool documents available from HRSA, and we've seen some from Medline Plus, and thank you to our National Libraries of Medicine friend who's doing Medline Plus. I'm curious from both of you if those resources are in other languages, because we need to be aware of this as we're dealing with lots of different types of patients in our country.
Well, thank you for that. The video that we tried to play, actually, part of it's in Spanish, and that's kind of, I think it really makes the message come across most strongly. And one of my colleagues from Colorado, who I saw last week at a meeting, shared with me that actually she does teaching, and just to bring this point home of health literacy and the challenges, she starts off, she said she goes at least 10, 15 minutes. She says she goes to the point where the audience is really uncomfortable, because she'll talk to an audience like this and speak in Spanish. And her message is, now you understand how uncomfortable it can be if English is not your first language. And then she goes into a whole talk, and I thought that was very powerful to hear about that. We're constantly working to provide materials, certainly the federal government side, where, funding to try to translate them into other languages. I can tell you wherever we can, we do that. And I will just share that we did a health fair several years ago. And actually, we got IRB approval, but we also did a little bit of research in looking at who these people were. We did head and neck cancer screenings. But the cool thing is the population, it was done at a local mall. So the population is very, very diverse. And being an epidemiologist, I just had to find out who lives in that area, who's likely to come. And we actually did the very quick intake in 5 different languages. So, that challenged us, too, to provide the referral information for those that needed referral and take the health education information. Hats off and thank you to my colleagues at NIH, because much of their materials are at least bilingual in Spanish and in English, and we try to leverage whatever resources already are available. But we are cognizant of that and trying to work to expand that.
Thank you. So I see we have a bunch of questions from the audience. Just a reminder to the members, if you want to turn your placard. Excellent, great. So Nicole Holland, please.
I had 2. The first one is for Dr. Acharya. I saw that you had asked the physicians what would be helpful within the EHR from the dentists. Was the reverse done?
So we didn't necessarily run a study, but what we tried to do was we already knew from a dental practice perspective that almost 50-60% of the information within the electronic dental record, it so happened to be my doctoral dissertation thesis, so I took a shortcut in terms of implementing, but clearly there's close to 55-60% of the information, medications, allergies, adverse reactions, problem lists, all these are kind of the common areas. So we didn't run a study per se, but we had access to some of that information that I, prior from working with the University of Pittsburgh, and also funded a couple of studies funded by NIDCR. We had done a R21, which focused specifically around an electronic information model in an electronic dental record, which was all geared towards, we looked at 4 different formats of the paper dental record from private practices, We looked at 2 electronic download record, vendor systems, and as well as, looked at patient records. So not only the format, but also the content in terms of how the dental practices are capturing this information. And we had published not within the Marshall Clinic, but prior to me arriving. So we had that information. So.
Just quickly, my second one is for everybody in terms of, has anyone looked at the use of prescription monitoring programs and prescribing practices as it relates to literacy and the integration within the work that you've done in your examples?
We've not done a formal assessment, but there is, within Wisconsin, in terms of especially opioid and other narcotic drugs being prescribed, all of our providers have access to this system. But within our own system, we are also trying to kind of, literally look at the retrospective data to look at how the practices have been, and there are some interesting findings that are coming. But we haven't done a formal assessment.
Okay, I can see that some of our audience members gave up with their questions. So I think what we'll do is to make sure we can get your questions on the record. We'll move to asking questions, if that's okay, and then we'll hold the responses at this point. But Chris Trudeau.
Yes, this is more just a question for John and kind of the regard. I'm Chris Trudeau. I'm a lawyer. I'm a health literacy lawyer. But so this is not the health literacy part. This is my lawyer hat thinking. Have you run into problems with the corporate practice of medicine, corporate practice of dentistry when you do the co-location issues? Because that's one of the things I'm kind of thinking from a legal standpoint. I think it's fantastic from a health literacy standpoint and just a healthcare access standpoint to co-locate these issues. But you do run into some of those regulatory regimes, I think, where you have to kind of come up with interesting corporate models. So that was kind of my question to you, is kind of how are you navigating that, and what are your recommendations for other places who don't have the backing of such a large organization to come up with these models, let's say in smaller towns or smaller places that are covered by by smaller groups? And so that was my question.
Jonna?
So I guess I had a comment and a question. A lot of folks have brought up the idea of oral health and who's prioritizing it. So obviously HRSA is. So I just wanted a little bit of a shameless plug as a Robert Wood Johnson Foundation clinical scholar. So RWJ is definitely looking at oral health integration. And we sort of talked about integration from the patient perspective. So PCORI and Oral Health is really another big organization that is sponsoring this stuff. So my question comes more to the and I guess we're not answering it, to the integration, and that a lot of us have, to Dean's point, if you take 1,000 patients, very few of them are actually getting to all the things we're talking about. So really being mindful that we really do need to get out of the four walls of medicine and into the community. So for our vulnerable patient populations, there are models where, like, right, the famous model is putting blood pressure cuffs on barbershops, right, and putting them on. So thinking about, faith-based organizations and other community organizations on how we can bring oral health to the community, because patients aren't coming to us.
Thank you. Ms. Jennifer Delaha?
Jennifer Dillahay, Arkansas Department of Health. This question is for Dr. Jaskov. I was thinking about integration of kind of basic preventive services and oral health in the light of some of the maternal, infant, early childhood home visiting programs, and wondered if you were familiar with that and if you would speak to the potential opportunities for this in those kind of settings.
Yeah, so we'll put that in the record, but we have to go to
We'll talk later.
Linda Harris, please.
Thank you for your presentations. I was kind of trying to think about how to take our theme for the day a little bit more literally. And the way I interpret it is, the question is kind of how do you use health literacy to drive the integration between these two disciplines. And I haven't really heard that yet. I've heard mentions of health literacy. Oh, we could do a little plain language here or there. So I would love to hear from you. What are the opportunities to use health literacy to drive the integration? For example, a couple of you mentioned electronic medical records, but what about the patient portal? Have you all looked into ways to explain that, to kind of help the patient understand the value of the integrated systems and take advantage of it in some way?
Great question. Thank you for that. Dr. Willis.
I'm probably building on what Linda, I was sitting here thinking of pathways to realize this integration. And I know when I'm doing projects and trying to do theory of behavior change, I'm looking at the different cognitive theory of behavior change, theory of planned behavior change, social marketing. I'm doing a lot of different ideas, including motivational interviewing, and motivational interviewing came up here. But my concern was that we don't always teach professionals how to carry out those behavior change models, whether it's dentistry or the medical practitioner, but we use them on the patients. I use them all the time on the patients and said, this is what I want to do if I want you to get vaccines. So I'm not sure whether any of your models took any of that into consideration. The behavior change, someone brought that up earlier, true behavior change models for practitioners.
Thank you. I think all of the flags are down. I think we've got 2 minutes for other questions from the audience.
I think we have it.
Okay.
So I want to thank the panel very much for their very erudite discussion. Now, we do have some very important questions that were asked just a few moments ago, and I really would like to have a discussion about that. So let's take a 10-minute break. And I think when I come back, we'll just ask, there were 1 or 2 questions that I would like to be answered, and we'll just review that at the break, okay?